Thank you, and greetings to everyone. I must say that I have some experience in the area. Some time ago, I made a presentation. I started with this slide, controlling blood sugar in the ICU. It was something full of hope 10 years ago, followed by bitterness, regrets, failures in the clinical setting, and the whole thing has sort of collapsed since then. So 3 periods: controlling blood sugar in the ICU, first period up until 2000. It's really the heart surgeons that at the time were treating a lot of diabetic patients, not much interventional cardiology at the time, and indeed they were dealing with multiple coronary issues, complicated bypasses, and cardiologists realized that infections were getting more and more frequent, and they had to have more and more repeat surgery in unbalanced diabetic patients, more so than in diabetic patients with a good control of glycemia. And between 87 through to about 2000, there was a reduction to the tolerance of hyperglycemia, so more aggressively providing insulin treatment. Second chapter, 2001, the fairy tale, the dream coming true. So here you have Cinderella. Yes, she lives in Louvain, Belgium. She's from my town, believing the tale. And we see an unprecedented reduction in mortality. If you weren't working in the ICU in 2001, this was a publication made by Louvain Hospital in 2001 on relative mortality decrease through stricter, tighter control of glycemia, bringing it down between 80 and 110. That's 4.4 to 6.1 millimoles per liter. Reduction in mortality, but more than that, mortality amongst long hospital stays, those that stayed in the ICU for over 5 days and therefore could truly benefit from the positive effects of the treatment. An effect was also noted on hospital mortality. What's more, making this an even better study, it was seen that better the glycemia was controlled, the lower the mortality rate. So after this fairy tale period, 2006-2009, disappointment, disillusionment with an inconvenient truth, the failure of all the confirmation studies, including glue control that I coordinated. Philippe Devos was the main investigator. It was published in 2009. You may have already seen these slides. We included 1,108 patients randomized into strict tight glycemic control with this target here, or a more liberal target than intermediate target. We had 2 groups of patients, comparable on all scores, a predominance of medical patients. From general medicine, we had an Apache score of 15, so expected mortality at about 20%. And everywhere, with the exception of the proportion of pre-existing diabetic patients, we had a good balance between both groups. So they were really comparable. More insulin, of course, was administered to those patients that were randomized into intensive insulin therapy, so more insulin for a longer period. And we were able to discriminate in a satisfactory way both groups, although we were not quite within the target for the intensive group. Despite that, we were not able to achieve significant differences in mortality between the groups, 15.3 and 17.2%. So we see a very slight excess mortality in the intensive insulin treatment group. With the multivariate analysis, luckily, we see there was no excess mortality as a result of our intensive treatment. The nice sugar trial, Australia, New Zealand, Canada, the US. This was a study published in 2009 in the New England Journal. It was presented in Brussels in March 2009. We see excess mortality over 90 days for 6,000 patients. So at 90 days, excess mortality in the tight glycemic control group. When we compared our study plus the other studies available then in 2010, including a more recent one by Pierre Calfon whom I saw in the room, we see no benefit coming out from tight glycemic control on mortality. And out of this data, what do we see coming out? Even in the framework of large randomized control studies, it is very difficult to achieve the target set at the outset. So that's an important thing to take into account. After 2009, after the nice sugar and glucose control studies, we enter this new period where all the data were reviewed. We see that controlling blood glucose is important. It's complex. You have to get by steps. There's a complexity in the types of devices used to control and check glycemia. The types of devices used to deliver insulin, this is the pump or the IV injections, and the therapeutic algorithms to calculate the proper dose of insulin are also different. There are different types. There are disparities, of course. And what was more complex to analyze was the level of motivation and experience and level of experience of the nursing team. I think that's a highly discriminating effect. So something that works somewhere won't necessarily work somewhere else because of these elements of disparity. And the changes in the nursing workload. We looked at this study. Again, we saw that the tight controlled blood sugar patients, well, the time of control was 17% more than in the so-called liberal treatment group. And that has consequences. Here's a signal that shows us that since we're tightly controlling glycemia, we're increasing the incidence of hypoglycemia. If you look at this meta-analysis by Judith Jacoby published in 2012, we see a multiplication by 5, a factor of 5 of mortality in patients that had hypoglycemia as opposed to those without hypoglycemia. And therefore, intervening not only does not improve mortality, but we could actually aggravate it because of an increase in the case of hypoglycemia. Here's a retrospective study which shows that we see an increase in mortality after adjusting for a severity, even with only one event of hypoglycemia, less than 90 milligrams per liter. So conclusion, here we combine 3 studies, the Dutch one, the glue control one, and the American one. We see an increase in mortality after adjustment, even after one hypoglycemia event below 90 decigram per liter. And it is understandable that the physiological response to hypoglycemia disrupted if there is aggression. So you and I, if we go into hypoglycemia, we stop secreting insulin, but patients continue to get insulin if hypoglycemia is not detected immediately. Glucagon, adrenaline, growth hormone, cortisol are already high in those patients, but are part of the mechanism that is activated in hypoglycemia. Therefore, it is more difficult to respond or to deal with hypoglycemia in these patients that are under attack, as it were. So this is where we are. Even slight hypoglycemia or severe hyperglycemia and high glycemic variability, all 3 of them are associated, I'm not saying they're causal agents, but they're associated with a poor outcome. And these can be synergetic elements. Their association with mortality increases when a second factor is present. And this is what came out of this American registry analysis, 24,000 patients, 100,000 patients, showing higher chances of dying when there's severe hypoglycemia, severe hyperglycemia, etc., than when there is no problem with blood glucose. So there is severity and variations, but it's quite tempting to say that you want to avoid hypoglycemia or severe hyperglycemia and as little variation as possible. Therefore, the present recommendation is to try and avoid these strong variations. And so these are the recommendations that we worked on with Carole, a group of experts, Frédéric Vallon, and others. So what we say is that you can't have a universal glycemic target. However, the glucose target should not be less than 10 millimoles and probably not less than 4 millimoles for the lower target. Performance can be improved with more nursing power, better nurses, better devices, better algorithms. Therefore, there is no one universal recommendation. But the recommendation is to avoid even moderate hypoglycemia, avoid severe hyperglycemia, and minimize variability. So on the pathological scale, we collected data over decades, and we now have a better understanding of the mechanism. So the initial Louvain target between 80 and 110 milligrams per deciliter, considered as normal glycemia, does not make much sense in these patients that are under attack. It's okay for you and I that get a blood test just to make sure that we don't have glucose intolerance, but it is not normal glycemia in patients under metabolic stress that is not that is feeding, that is receiving treatments like vasopressors. And this cannot be considered as physiologically normal for patients under stress. These patients under stress probably developed an adaptive mechanism, i.e. insulin resistance. This is a wonderful study published in 2012 by Sutters, senior and junior. They are Dutch. One is endocrinologist, the other is a surgeon with an interest in metabolism. And they looked at a lot of the evolution of the species. They are quite Darwinian, as it were. So species have developed insulin resistance, and those species had a better survival rate than those that could not develop insulin resistance in response to a stress. Marek and Bellomo, always very provocative, published their opinion in Critical Care in 2013, saying that stress hyperglycemia is probably a survival response. And they showed here the level of cortisol, Virginie will like this, for each animal species. And man is right here next to the rhesus monkey. And these are the two species that can secrete the highest levels of cortisol in response to a stress, as opposed to the koala. The koala will stay asleep comfortably on his branch. Cortisol will stay the same, and therefore insulin resistance will not peak. So with three authors whose names are up here on the screen, we published something in a journal where we re-studied the physiology of resistance to stresses, in particular insulin after a stress. So the brain is the leading organ to be stimulated. Then it goes to the immune system, and then perhaps the fatty tissues that kick in, although we don't know the pathophysiological response specifically. And then the GI tract hormones, they also play a role in this uncontrolled catabolism and resistance to anabolic signals, and in particular resistance to insulin, which is essential to survival. If you look at this, you see that insulin resistance is useful in delivering enough substrate that will produce in turn enough glucose for those tissues that are essential to survival. So just a summary. So it is essential, it's vital to develop insulin resistance, to provide enough substrate for the liver and other tissues that produce glucose, since glucose is vital for those tissues that are essential to survival. We published this in Anesthesiology in 2011. So here again, you have the agents that are responsible for insulin resistance after stress. So number one, the brain, then the inflammatory system, and then the immune, more general immune system. Now let's look at data from actual patients. This was published by a team of New Zealand bioengineers. This is insulin resistance as calculated by mathematical models on day 1, day 2, day 3, day 4 after heart surgery. And these data does show insulin resistance. This measures sensitivity, so it's the opposite, but it shows the same thing. And the variability of the response to insulin is higher in the acute phase of the stress or aggression than on day 4. That explains why those patients that we treat with insulin, for which we want to achieve a target, for them it's more difficult to achieve that target in the acute phase than after a few days, and we see that in the clinical setting every day. So what do we do once we know that? Either we say, well, there's no relevance, so who cares? Or we adopt what we actually do in practice in most departments. So we adopt a soft compromise. So you use the data we have. We set a target for everyone. We make a compromise in terms of availability of people and equipment. So we choose 90 to 250 milligrams per deciliter as a glycemia target. Or we try and do better and try to investigate and actually slow down, take a step back, and ask the questions to which we don't have the answers for yet. So what are they, the unanswered questions? We need a better delineation of the risk associated with tight glucose control. Probably when we're too aggressive, we probably introduce excessively high variations or increase the risk of hypoglycemia. So here we probably have to think about the most appropriate glycemic target depending on the type of patient. So neurological patients, we know that hypoglycemia can be very bad for them. Diabetic patients as well, because over time their cells have developed defense mechanisms against glycemia. We can be less tight with them than for non-diabetic patients, but we have to confirm that on the ground. Blood glucose measurement techniques have to be refined as well, but gone are the days when we can use capillary blood and point-of-care devices. That's good for patients at home. In the ICU, we have to vasoconstrict, use at least the blood gas analyzers, analyze venous and arterial blood. Continuous glucose monitoring and insulin algorithms, come to that in a minute, and a combination of the two via closed-loop systems. That's probably the way ahead. So continuous glycemia monitoring, won't go into the details, but there are interstitial and intravascular systems using different techniques. These devices, as far as I believe, are good as research tools. Unfortunately, some manufacturers consider that profitability is important. They've withdrawn from the market because they felt there was not enough money to be made in producing these devices, and we can't get any more experimental data, unfortunately. So we started a study in which we hope to enlist 100 patients. So we're studying one of these devices, and in our department we compared a target-oriented treatment using monitoring, continuous monitoring system versus no continuous monitoring. And what we saw is that we increased our time in the range using continuous monitoring. We also largely reduced hyperglycemia. We also improved, that was hypoglycemia, sorry. We also improved the rate of hyperglycemia. So these continuous monitoring devices make for better performance and higher quality of care. Why? Reducing the nursing workload, since glycemia is displayed on the screen and there are no specific checks that need to be made. Modelization of insulin sensitivity. The main hope comes from algorithms that are based on the expected insulin sensitivity, or you could see it insulin resistance. It varies over time. So the hope is to have mathematical algorithms that can help you to anticipate the result on the basis of glycemia and quantity of insulin. So you'd be able to calculate insulin sensitivity and therefore predict insulin sensitivity in the next few minutes, thus increasing the quality of glycemic control. So these are virtual cohorts of patients that were studied, i.e. databases. We also worked with a Danish university to validate this result when this kind of intervention is used. So the glucose-safe algorithm, you improve the time in target. This is cumulative sensitivity. You see an improvement day to day. And obviously, this type of development is promising, and we need to look more at them. So closed-loop systems, this is a combination of continuous monitoring and algorithms that help you calculate patients' insulin sensitivity. That is probably the way of the future, and so that is our source of hope. Thank you.